Hello, good afternoon, good morning, good evening. I know we have people joining us from time zones literally all around the world, so thank you for joining us whatever time of day it is where you are. This is Kim McCleary. I am President and CEO of the CFS Association of America, and we're delighted to have you here with us this afternoon, as it is in Charlotte, North Carolina, and afternoon where Dr. Leonard A is in Chicago, Illinois, for our fourth CFS Association webinar in our 2010 series. And we're delighted to have over 300 people having registered for today's program, and I can see by the little dashboard on my screen that people are joining us as we speak, and we'll get underway here in just a couple of minutes. The registration process that we use for our webinars lets us know, based on the information you graciously provide, that about 2/3 of the folks that are here with us today, for them this is their first webinar, so welcome and thank you for taking perhaps a somewhat intimidating step forward to make use of this new technology that we think is just really a super way to deliver programming with a very low cost and also very little effort required on the part of folks who very often find it difficult to leave the house or to even go across town or let alone across the country for presentations from top experts like Dr. Jason. So we're delighted that you're here with us today. Also through our registration process, folks were able to submit questions in advance, and we have shared about the first 200 that came in with Dr. Jason, so he's had a chance to incorporate some of your questions already into his presentation, which is just great, and Lenny, I thank you for taking the extra time to do that. And we'll also have questions after his slide presentation. So just to orient those of you who are new to the Citrix GoToWebinar features, you should see a control panel on the right side of your screen that has a little box where you can type questions. Those actually will come into me, and then I will forward kind of an aggregate list as they come in to Dr. Jason and while he's speaking, so he'll have those when he completes his presentation. So as you think of questions, don't hesitate to just type them in right at the time, and can kind of assemble those and group them. Many times we find people have very similar questions, and we're able to get through more of them that way. I did want to just let folks know that Dr. Jason, as expert as he is a PhD and not an MD, and his specialty is not the practice of medicine, so he's not able to address individuals' questions about their specific symptoms or treatment or diagnosis. So we will have some clinicians in our series and may be able to get to some questions of that nature later on as the spring and summer programs take place. So again, if you've just joined us, thank you for being here this afternoon. We will be having a series of these presentations, and I hope that the software becomes easier and easier to use each time, because we've got some great speakers lined up for the rest of the year. Without further ado, because I know Dr. Jason has a jam-packed presentation for us on a topic that may sound a bit dry, but definitely is not when you start thinking about the impact of how the definition of CFS impacts both research and clinical care, and how the definitions and characteristic symptoms have been studied and grouped together over time. This is really sort of a bedrock foundational topic, and we're just thrilled that Dr. Jason is able to be here today. I know from the comments that we received with the registration, many of you are here just because this is Dr. Jason and the reputation that he has as not only a very prolific and creative scientist, but also as a staunch patient advocate and somebody who's been involved not just on the research level, but really in trying to bring this illness and its severity and its complexity to the attention of researchers and clinicians and government people. So we're, again, thank you, Lenny, for being with us. And if you haven't heard Lenny speak before, he is a professor at DePaul University, which is located in Chicago. He is a professor of psychology, but also works in the Center for Community Research there and is director of that center. He is one of the most well-published authors in the scientific literature on CFS, and I don't know anybody who turns out more papers from the data that he collects than he does. His group is just tremendously productive. He has been involved not only in case definition work, but in also some of the really important work that was done in trying to establish what the prevalence or the number of people who have CFS has been. First doing a study of nurses and then a study of a community population in Chicago, and I'm sure he'll share some of that with you. Dr. Jason has also served as an officer and vice president of the International Association for CFS ME. He is currently serving as an appointee to the federal U.S. Department of Health and Human Services Chronic Fatigue Syndrome Advisory Committee that will be meeting May 10th for its next session. And Lenny has also assisted the association with many, many projects over the years. We've been fortunate to fund some of his research, but he has also been very deeply involved with some of our clinical education efforts and did a series of Train the Trainer presentations with Dr. Charles Lapp, who will be joining us for a webinar next month. Many of you may not know that Lenny is also very well funded and published in the area of alcohol, tobacco, and drug abuse, and has done a lot of important work for those communities. So I think, Lenny, you and I met maybe in 1992, so we go back quite a long way. And it's a pleasure to, I can't say be here with you today because we're sitting 1,000 miles apart, but to be together with this great audience this afternoon.
Thank you. Happy to be part.
And I am behind in my slides here, so I've had that up while I've been talking about him without his picture, but maybe he's okay with that.
That's perfectly okay.
I'll try to get my slides to advance, but for those of you who haven't been with us for a webinar in the past, there he is. I have kind of what we call the controls right now, and I'm about to turn those over to Dr. Jason so that you will see his slides instead of mine. There's a little bit of a delay as we make that transition, and you may see kind of that waiting room slide again, and then as we advance our slides, it takes just a few minutes, or actually just a few microseconds for the picture to be the same for you. So if you see a little delay, that's what that is due to, and hopefully we won't have any other technical problems as we go through. We are recording this session today, and we'll be posting that on our website as well as our YouTube channel, and we'll also have the slides up. And you're seeing now your waiting room quote-unquote slide, and then we will soon be treated to Dr. Jason's presentation. So take it away, Lenny.
Okay. Do you have my slides up, Kim? Can you see them?
I still see the, did you hit the show my screen button?
Yeah. Okay. I hit the button, and
there we go.
Also,
now we see it.
am I up?
Yep, you're up.
Okay, good. All right. Thank you, Kim, for the introduction. And I appreciate the opportunity to share with the audience some of my thoughts about the current chronic fatigue syndrome case definition. And I refer to this as ME-CFS, and ME refers to myalgic encephalomyelitis. This is a very exciting time for our field, as major discoveries are occurring in a number of critical areas that are helping us better understand the etiology and pathophysiology of this illness. However, I firmly believe and hope to show during this presentation that our current case definition could be a major impediment to replicating findings across different laboratories. For if investigators select samples of patients who are different on fundamental aspects of this illness because of ambiguities with our case definition, then it will be exceedingly difficult for investigators to consistently identify biomarkers. And this could lead to more psychogenic explanations of this illness. And I hope during this presentation to expand on these ideas. Occasionally you're going to hear an L rumbling by, and that's because I'm at DePaul University in Chicago, and my building at DePaul is right next to one of the elevated L's. So please, hopefully you won't be too distracting to hear that noise. As you can see on this slide, there's a stack of playing cards, and it's as if to make a pyramid. Now, if the foundation or the first level of these playing cards is not sturdy, and that's this first level right here, if that level is not sturdy, for those of you who have tried to make a pyramid, then the middle and upper layers are vulnerable to collapsing. A sturdy foundation is required for any progress to be made, and really all science works like this. The case definition is the foundation for any scientific endeavor, as well as our particular field. A case definition is a set of rules that allows investigators and clinicians to determine who has and who does not have an illness. If we cannot do this diagnostic activity in a reliable way, all progress in a scientific area will be shaky and vulnerable to collapse. As I have said on the last slide, case definitions determine who have and who do not have an illness. This activity has enormous influence on estimates of how many people have an illness. If a case definition selects too few people and prevalence estimates are inappropriately low, then less resources and attention will be devoted to that illness. On the other hand, if case definitions select too many people, in particular people who do not have the illness, it will be exceedingly difficult to consistently identify biomarkers. Case definitions also are critically important in identifying viruses or even a retrovirus that might be implicated in the etiology of ME/CFS. You see, if scientists select widely varying individuals as having ME/CFS, and in particular, if some of those individuals do not even have the illness, identification of biomarkers will be compromised, as I'm sure you all recognize. Finally, even our treatments are strongly affected by our case definitions. For example, if our case definition inappropriately selects some individuals who have primarily psychiatric illnesses, and then treatments are provided that cure those psychiatric problems, investigators could mistakenly conclude that the illness is psychiatrically mediated. And this possibly has occurred in our field. On this next slide, one has a Venn diagram and a circle, and we'll see some more of these types during the presentation. And this will help explain some of the confusion about the ME/CFS case definition. And that is because fatigue is experienced at any one time by about 25% of the population. So that's about 1 out of 4 people. If you walked up to them and said, "Are you feeling fatigued?" they would say they are. The other 75% of the population feel fatigued after strenuous activity. That's the majority. So everyone feels fatigue at some point, but for most, the fatigue goes away completely when people rest. So here's the problem. Everybody else experiences fatigue and then gets over it. So it's not unusual for medical personnel and family members of patients with ME/CFS to say, we've experienced fatigue and are able to recover. Why can't you? Many inappropriately at this point conclude that this illness must be psychological. And as you probably know, the name chronic fatigue syndrome trivializes the seriousness of this illness. That further compounds the problem. In a sense, it's like saying that a person with bronchitis or emphysema had chronic cough syndrome. About 4 to 5% of the population has what is called chronic fatigue, and that means that they have had at least 6 or more months of fatigue. In other words, about 1 out of every 20 people have 6 or more months of fatigue. And this makes chronic fatigue one of the more common chronic problems affecting our nation. So the question is, among these people, this particular 4% here, that's the key question, how many actually have ME/CFS? And this is the issue that the case definition attempts to solve. There are a number of reasons that people might experience chronic fatigue. For example, a medical illness like cancer can cause fatigue. So this circle here is people have medical illnesses, and this is chronic fatigue. So you can see a certain amount of chronic fatigue is caused by medical illnesses. Also, an affective disorder, such as melancholic depression, can also cause a person to be chronically fatigued. So people who have depression would be in this circle, and you can see chronic fatigue is in this red circle. So these people here have depression that could very well be influencing their chronic fatigue. This group right here. In addition, in our increasingly fast-paced technological society, some people are overworked and overstressed. And this can be a reason they feel 6 or more months of fatigue. So this is this group here. This group who's overworked, overstressed, could certainly be causing, among this fatigue, it could be explaining this proportion of fatigue. Yet these people who are overstressed and overworked, if they took a vacation or rested, they would no longer feel fatigued. It's very easy to see that there are many reasons for a person feeling chronically fatigued, and yet here is where the diagnostic confusion occurs. These individuals do not have ME/CFS, and if we inappropriately bring these individuals into our case definition, our studies of etiology and pathophysiology will be based on mixtures of samples, of which some have ME/CFS and others have different illnesses or conditions. So we're going to go through this point again and again through this presentation because it's such an important one. On this slide you see the international case definition. The 8 core symptoms are on the slide. In 1988, investigators at the CDC took an illness that had been called myalgic encephalomyelitis by Ramsey and others in Great Britain and renamed it chronic fatigue syndrome. Now in 1994, a major revision occurred, and this is called the Fukuda criteria, because Fukuda was the first author of the paper describing the revised criteria. So we're going to be talking primarily in this presentation about these particular criteria. So we'll call them the Fukuda and other 1994 criteria. And as you can see, to meet the case definition, a person would need to have 6 or more months of chronic fatigue and 4 out of 8 core symptoms. These 8 core symptoms are actually on this slide, but here is the conceptual problem. We know that 3 of the critical symptoms of ME/CFS are unrefreshing sleep, post-exertional malaise lasting more than 24 hours, and persistent or recurring impairment in short-term memory or concentration. And these in red are the critical symptoms. But these 3 symptoms are not required of everybody. In other words, if we have core fundamental symptoms that patients with CFS almost always have, but with the Fukuda criteria, a person could have none of these symptoms and still meet the case definition. Hard to believe, but that's the case. Let me give a concrete example of what this could do for investigators. Say there's 2 studies going on in different parts of the country, and one investigator selected patients who had these 3 core symptoms: unrefreshing sleep, post-exertional malaise, impairment in short-term memory and concentration. So one group had these 3 symptoms plus headaches, so they met criteria. They had 4 symptoms. And the other investigator selected patients who only had these symptoms up here and none of the core symptoms. These 2 laboratories would have an individual who met the criteria for CFS, but they're very different. It's like comparing apples and oranges, and ultimately replicating the findings from one lab to the other would be close to impossible if the basic symptoms of these 2 groups differed that prominently. Here we have some fancy terms, Polythetic criteria. What it means is that scientists who developed the Fukuda case definition in 1994 allowed researchers and clinicians to select 4 out of 8 symptoms. That's what polythetic means. So you have a choice of 4 out of 8 rather than saying you have to have these core symptoms. So if you have a choice, that's the way the Fukuda criteria was developed, but they could have done it differently. They could have said these are basic symptoms. They could have said that a critical symptom is, for example, post-exertional malaise, and they would say that you'd have to have it, but they didn't say that. Is it not possible that it would be more methodologically sound to require such symptoms in the identification of patients? We'll come back to this issue. Let's give another example of the types of problems that the current case definition might encounter. One of the more prevalent psychiatric conditions is major depressive disorder, and many people with this psychiatric condition have both chronic fatigue and 4 Fukuda symptoms, such as unrefreshing sleep, joint pain, muscle pain, and impairment in concentration. But major depressive disorder and ME/CFS are 2 distinct disorders. Let me just emphasize, there can be overlap. Some people with ME/CFS certainly might have a major depressive disorder, but there is pure major depressive disorder, and there is ME/CFS does not have major depressive disorder. And most people with ME/CFS have, for example, the types of physical exertion, night sweats, sore throats, swollen lymph nodes. People with major depressive disorder do not have those. Illness onset with ME/CFS often occurs over a few days or even a few hours. With primary depression, generally it's a gradual onset. So the question is whether some research groups studying ME/CFS have mistakenly brought into their samples patients who have a primary psychiatric disorder and not ME/CFS. If these investigators thought there was no difference between psychiatric disorders and ME/CFS, they would not see this as a problem. However, these are distinct illnesses. If you asked a person who had major depressive disorder, what would they do tomorrow if they were well, they would probably not know. They would not know what it is they want to do. That's part of the illness. In contrast, if a person who had ME/CFS was asked the same question, they'd probably start giving you a list of activities they've wanted to do but have been prevented from. You can see these are 2 classic different illnesses. Combining them together is a major conceptual methodological problem. In this diagram, you can see that those with chronic fatigue, that means 6 or more months of fatigue, are only a small proportion of the people who have ME/CFS. There's only a small proportion of this group here within a larger group with chronic fatigue. Many people with major depression also have chronic fatigue, this group right in here. But its slippage due to the case definition allows investigators to bring into the ME/CFS category all those with depression and chronic fatigue. Then these investigators will be studying mostly depression rather than ME/CFS. In a study I conducted with Caroline King a number of years ago, we selected 2 groups of patients, those with depressive disorder and those with ME/CFS. In that study, we were able to differentiate these 2 groups with 100% accuracy using the variables that are on this slide. And these were the variables. Percent of time fatigue was reported, post-exertional malaise severity, unrefreshing sleep severity, confusion, disorientation severity, shortness of breath, and severity of self-reproach. You can see here we're talking about severity, not just occurrence. That's a very important issue we'll talk about later. So we were able to differentiate these 2 groups. And the differentiating variable, shortness of breath, for example, is not even found on the Fukuda criteria. Patients with depressive disorder have high levels of self-reproach, lots of negative things they say to themselves. But this is not found among patients with ME/CFS. This study suggests that these are 2 separate disorders, and it is critical for our case definition to distinguish these different illnesses. Is it possible that this failure to differentiate major depressive disorder from ME/CFS has led to varying prevalence rates of this illness? Let's look at that on this slide. From 1997 to 2007, over a decade, the CDC presented prevalence data suggesting that rates of ME/CFS have gone from a relatively rare disorder affecting maybe 20,000 people to one affecting more than 4 million in the United States. So in 1997, we see 4 to 8 persons per 100,000 in a 4-city study. And then in 2003, we see the rate go up to 240. In 2007, the rate going up to 2,540 cases of CFS per 100,000. This is an exponential, almost unprecedented rise in a disorder. As you might imagine, I am skeptical about the CDC's sizable increase in the number of estimated patients with ME/CFS in the U.S. over the past decade. The question is, what might account for these escalating rates? And it is possible that changes in the case definition might play a large role. I contend that changes from 1997, which is this little sliver right here, this is cases per 100,000, to 2003, that this jump that occurred might be due to the way the CFS cases were identified. The larger jump from 2003 to 2007 might have been due to changes in the operationalization of the case definition. I might add that similar increases in prevalence rates have been reported by some investigators in Great Britain. Now let's try to figure out what these changing rates are about and see if we can come up with some possible explanations for that. In the late 1980s and early 1990s, the CDC engaged in a prevalence study that involved having medical personnel in 4 cities identify patients who have CFS. And then these individuals were medically examined. So individuals were referred by the physicians, and then they were evaluated to see whether or not they had the illness. The findings released by the CDC in 1997 indicated that CFS was a relatively rare disorder. affecting about 20,000 people. Yet if the physicians did not believe that CFS existed, they would not refer patients to the study. In addition, if patients didn't have physicians because they were poor due to the illness and having many of their resources having been used to try to get medical care, then they also would not been referred. Therefore, these findings were likely underestimates of the true prevalence of CFS. And as we said earlier, if an illness is perceived as relatively rare, less public and federal resources will be devoted to that illness. Our group in Chicago used a different method to collect data by telephone, and we would call a random sample of people in the Chicago area. Those who had the core symptoms were invited in for a complete medical and psychiatric examination. This is called community-based sampling. And using this method, we estimated that about 800,000 people or more had ME/CFS, which was, as you recognize, considerably higher than the prior CDC estimates. In addition, we found that 90% of the patients had never been diagnosed with ME/CFS prior to our study. You can see this is the rate at the CDC, and this is the rate that we got from our Chicago study. I might add that in 2003, the CDC also reported on a community-based prevalence study, and their findings were comparable with the DePaul sample. However, in 2007, in another report by the CDC, prevalence rates had soared. It is possible that changes in the case definition accounted for these increases. But let's first go back to considering essential elements for an illness case definition to see where the problem might be. Criterion variance is a complex term, but it's a critical one. As I've been emphasizing, it's important for two independent investigators to identify comparable patients for science to progress. But if your rules for identifying who is a patient and who is not a patient differs, then problems will occur with the scientific enterprise. And that's really what this criterion variance is about, and that's why it's such a critical concept for scientists. So any good case definition has to be able to develop ways of defining symptoms so that different clinicians or researchers would agree as to whether a patient has a group of symptoms or not. On this slide, the vertical axis refers to intensity of symptoms, where 0 would mean very low intensity, that's here, and 100, very high intensity. The horizontal axis refers to the Fukuda symptoms. The orange bar refers to how a person feels today, and the yellow bar refers to how a person feels during their worst period of the illness. As you can see, this person has very low intensity symptoms, but still there are 4 symptoms. This person's actually a healthy individual. What this indicates is that the Fukuda symptoms are commonly reported by the general population. On this slide, you see a completely different pattern. This is a patient with ME/CFS. As you can see, it's the intensity or the seriousness of the symptoms that differentiates a person with ME/CFS from a healthy person. In other words, you cannot just rely on the occurrence of a symptom, but rather the intensity of the symptoms to really differentiate those with and without ME/CFS. Let me give another example of this important point. Here we have 3 groups of patients represented on the slide. One group has ME/CFS, one group has what's called MDD for major depressive disorder, third group is actually healthy controls. If you ask these 3 groups whether they've experienced 6 months of fatigue, you can see on the vertical axis that the ME/CFS group is really no different from the depression group. There's no significant difference between these 2 groups. They are different from the healthy controls, but these 2 groups are not significantly different. both groups experience chronic fatigue if you ask them if they have experienced the occurrence of it. Close to 90% or more of the individuals, and of course in the ME/CFS group almost 100%. But here are the same three groups, but this time we examine the severity of the fatigue over the past 6 months, and not just the occurrence. The severity of the fatigue differentiates these particular groups. So from 0 severe to 100 severe, the ME/CFS group is saying it's about 80 in terms of severity. It's pretty high. The MDD group is less than 50 on a 100-point severity item. The control group, of course, much lower. So on severity, you can differentiate these two conditions, not on occurrence. Again, an important methodological point. It's also important to make sure that information is elicited from structured interview schedules so that all questions are asked in the same way. So let's kind of just take an example of that. What if you were trying to assess post-exertional malaise and you asked the person, do you have prolonged, greater than 24-hour generalized fatigue or malaise after previously tolerable levels of activity? And this is a problem since you got chronically fatigued. Well, to that question, we found that 59% of people with ME/CFS answer yes. But think about this question. It's complex. There's many parts to it. Some people may get lost trying to understand what is even being asked. For example, what is previously tolerable levels of activity? People might interpret that differently. So it's critically important to have good questions asked that really assess validly the patient's symptoms. And it's easy to get it wrong, and that's why it's so important to have an interview schedule that lays out how to ask each question on these surveys. Well, in order to deal with a number of these problems, Reeves and his colleagues at the CDC in 2005 developed an empiric definition, which was supposed to identify people with CFS with more precision. It's beyond the scope of this webinar to discuss all the criteria of the CDC that they proposed, but let's examine one part of the criteria, and that which deals with identifying whether a person has sufficient disability to be included as a person with CFS. In order to meet the threshold for disability, according to the Reeves empiric case definition, they used an instrument called the Medical Outcome Survey, short form 36. And let me again emphasize that this Reeves case definition was the one that ultimately was used with the Georgia prevalence study that indicated that over 4 million people have CFS. So on this medical outcome survey, a person could reach the disability criterion of being indicating that they met it for CFS by scoring lower than 25th percentile on one or more of the following scales. You can see the scales up here: physical functioning, role physical, social functioning, but in red, I want to emphasize role emotional. So if you just made the criteria for role emotional, which means problems with work or daily activities as a result of emotional problems, you would then meet the disability criteria according to the Reeves definition, the empiric definition. The older Fukuda criteria never mention that emotional problems should be the reason for substantial reductions in functioning. So here we have a major change. And this is the problem with these criteria. Using the lower 25th percentile for this role emotional scale, every person who suffers from clinical depression would meet the disability criteria for CFS. Our group in Chicago recently used the Reeves empiric criteria with two groups of patients, those with CFS and those with major depression. We found while all those with CFS were identified as having CFS, we found that 38% of those with major depressive disorder would also be classified with CFS, and that's what this green bar indicates. In other words, Reeves and colleagues' empiric case definition was over-inclusive and possibly brought people into the diagnostic criteria that did not have ME/CFS. Let me give a case example of one of the people that we tested who we thought kind of was misclassified. This person was a female with major depressive disorder. This female met all the criteria based on Reeves' empiric criteria, including role emotional functioning at the lowest 25% to meet the disability criteria. She demonstrated impairment with social and emotional functioning, two important traits of depression. But this person, on a measure of physical functioning, scored the highest possible score, indicating she had no difficulties with physical functioning. This would indicate that she did not have ME/CFS and yet had been misclassified based on the Reeves and other empiric criteria. Any screening or diagnostic test has to be able to correctly identify those who have an illness, such as ME/CFS, and also correctly identify people who do not have an illness. This refers to the sensitivity and specificity of a test. In particular, when you have a low prevalence illness, such as ME/CFS, unusual problems can occur, and these involve sensitivity, identifying those who really have the illness, and specificity, making sure you don't identify those who don't have the illness as having it. And Bayes' theorem is something that we're going to talk a little bit about because it has some very interesting implications for this discussion. Take if you had 100,000 people as an example, and say the prevalence rate was 0.42, which we found in Chicago. So that means out of every 200 people, you might have one person with ME/CFS. If you had 100,000 people, you'd have about 420 people with ME/CFS. If a diagnostic test had a 95% rate of sensitivity and a 95% rate of specificity, it would correctly identify 399 of the 420 people with ME/CFS. So that 95% rate would get most of the people, 420 times 95%. So in a sense, you'd get most of those people, 399. That's good. But here's the problem. If you have a 95% rate of missing people, of identifying people who don't have the illness as having it, if you take 5% times 100,000, you'll get 5,000. 5,000 here. 5,000 who do not have the illness will be identified as having it. Therefore, it's critical to identify with precision true negatives. You've got to identify those people who don't have the illness and not include them as having it. An example, if a person has major depressive disorder and not ME/CFS, you need to be very careful in not classifying this person as having ME/CFS. We've just published this study, and what it indicates is that the criteria of the CDC has poor specificity. That means it identifies people as having CFS when they do not have it. This article is posted online, and it will probably be visible within the next week for those of you who might be looking for it. To summarize, about 4% of the population has 6 or more months of fatigue. But 4% have chronic fatigue, and according to Reeves' CFS case definition, 2.54% have CFS. So that means over half, over the majority of people, of those 4% with chronic fatigue, basically the Reeves case definition is going to identify as having CFS. Mood disorders are one of the most prevalent psychiatric disorders. The 1-month prevalence rate of major depressive episodes is 2.2%. Isn't it interesting that the rates 2.54% and 2.2% are so close? Major depressive disorder can be confused with ME/CFS, as there are some overlapping symptoms with ME/CFS. Is it possible that some patients with major depressive disorder, MDD, also have chronic fatigue and 4 CFS Fukuda symptoms that can occur with depression? It is critical not to include such individuals in the ME/CFS case definition. And here is why it's so important for the case definition to get it right. If you classify the wrong people in your case definition, you might end up producing effects that do not accurately describe, for example, risk factors for the condition. Let's look at one issue: childhood trauma and chronic fatigue syndrome. One investigator, Heim, used the new Empiric CDC case definition and Wichita data to explore the influence of early adverse experience on risk for developing CFS. They concluded that childhood trauma was an important risk factor for CFS, with 62.8% of their sample having some type of early abuse. Whenever you have data that suggests a large percentage of the people have early abuse, then some individuals begin to wonder whether this could be a psychogenic illness. By contrast, using a traditional system of diagnosing ME/CFS, Renee Taylor and I found prevalence rates of sexual and physical abuse history among individuals with ME/CFS comparable with those found in individuals with other conditions involving chronic fatigue, including medically based conditions. Relative to those with ME/CFS who report such history, we found most individuals with ME/CFS did not report interpersonal abuse, and that's in red. Again, 2 different ways of selecting patients, 2 very different outcomes. Very important implications of these 2 studies for the case definition. Our group at DePaul used statistical methods called factor analysis with a sample of patients who had been diagnosed with ME/CFS to see if we could identify factors that were common in these individuals. And as you can see, we came up with 6 factors. And some of these factors, neurocognitive items, muscle joint symptoms, infectious symptoms, sleep post-exertional symptoms, are very familiar. But vascular items and inflammation items, like dizzy after standing, chemical sensitivities, these are actually not part of the Fukuda criteria. However, of interest, all 6 of these factors are part of another case definition called the Canadian Clinical Case Definition. So we're going to spend a little time talking about the Canadian criteria. Developed in 2003, in sharp contrast to the Fukuda criteria and the Reeves Empiric criteria, the Canadian criteria require specific symptoms, including, as you can see on the slide, post-exertional malaise, unrefreshing sleep, 2 or more neurocognitive manifestations, and at least 1 symptom from 2 of the following categories: autonomic manifestations, for example, lightheadedness, neuroendocrine manifestations, such as recurrent feelings of feverishness, and immune manifestations, recurrent sore throats. In 2004, our group compared these Canadian criteria to the Fukuda criteria and found that the Canadian criteria selected cases with less psychiatric comorbidity, more physical functional impairment, more fatigue weakness, more neuropsychiatric and neurologic symptoms. So a natural question we could ask as researchers, why isn't it being used more often in research? Well, one of the reasons for that is some of the difficulties with criterion variance some of the difficulties in having a questionnaire that can monitor the symptoms. And that's something that our group, as well as the CFS ME Association, tried to tackle a few years ago, where we took these Canadian criteria and tried to develop an ME CFS pediatric case definition. And what we tried to do was carefully specify the symptoms and then develop a questionnaire to assess them. And we presented some of our findings at the Reno conference that occurred last year. And we compared the traditional Fukuda criteria to the new pediatric case definition. We found the Fukuda criteria actually missed 24% of patients, pediatric patients, who had this illness, whereas our pediatric ME CFS criteria only missed 3%. Our criteria had 97% sensitivity, 100% specificity. So we felt that on one empirical trial, it seemed like these were good criteria. Over the last year, our group has been revising the adult criteria for the Canadian clinical case definition, and we're now collecting data on it. We also have developed a questionnaire to assess the symptoms in a standardized way. Let me provide you some characteristics of this effort that we're making with the Canadian criteria in our hope to have other people eventually use these criteria as well. This case definition indicates that the illness persists for at least 6 months, and the survey items specify that these symptoms should be assessed over the last 6 months. Each item, each symptom, measures severity and frequency. You want to measure both of these because something could be very severe, but be so infrequent it's not really an issue if it happens maybe once a year. On the other hand, something could be very frequent, it may be happening every day, but severity is so very low that it's not really a significant issue. So both things need to be assessed. Each topic needs to be carefully operationalized so that all people respond to the same questions. As an example, the criteria says that the fatigue should not be lifelong. Well, what does lifelong mean? You might have reliability problems if different people try to assess it different ways. So we have this way of assessing it. We ask our participants, who we give this questionnaire to, have you always had persistent or recurring fatigue energy problems, even back to your earliest memories as a child? By persisting or recurring, we mean that the fatigue energy problems are usually ongoing and constant, but sometimes there are good periods and bad periods. According to Hyde, stamina and endurance need to be very carefully measured, and the Canadian criteria tries to do this. Hyde believes that some patients are not chronically fatigued, but have lengthy times to recover following minimal degrees of activity. So a person who participates in very little activity, possibly to minimize ME CFS symptoms when compared to his or her same-sex peers, and becomes exhausted upon minimal exertion, should not be excluded from an ME CFS diagnosis. We therefore inserted questions that also identified those individuals who have low stamina and endurance, but currently have less fatigue because they are severely limiting their daily activities. Given the importance of post-exertional malaise, our group developed the ME CFS Fatigue Types Questionnaire, which does have a factor that measures this symptom. For example, physically drained or sick after mild activity. Our group has also found that this post-exertional factor has adequate sensitivity and specificity. We have tried to better operate substantial reductions in important areas today. Again, this is something that we referred to earlier when Reeves also tried this very difficult task to operationalize substantial reductions. However, when we examined role emotional scale that had been used in the Reeves empiric case definition discussed earlier, we found it had the worst threshold for identifying individuals with ME/CFS and identifying others who did not have this. We found that not only in our data set, but also when we looked at the literature and did a summary of the literature that has used this particular scale. However, vitality, social functioning, and raw physical had the highest thresholds. We now believe that these three subscales capture significant limitations in the person's ability to have energy and accomplish activities in life. So again, we're trying to be as careful as possible in not only selecting scales, but selecting cutoff points that possibly lead to good sensitivity and specificity, identifying those people who have the illness and not identifying people who don't have it. I certainly believe that in the future there will be even more objective measures of these Canadian criteria, as indicated by the following types of examples that you can see on the screen. For fatigue severity, possibly using what's called ectographs, which are able to measure behavioral abnormalities. For post-exertional fatigue and pain, possibly certain types of genes that following exercise, as the lights have found, are nice indicators of this construct. For unrefreshing sleep or disturbance of sleep, possibly a sleep study. Neurocognitive manifestations by possibly fMRIs, autonomic manifestations, ejection fraction decreases, as has been found by this particular group, neuroendocrine manifestations, abnormal cortisol levels, and immune manifestations by some of the work of Kevin Marr, Nancy Klimas, Marianne Fletcher. In summary, any scientific enterprise depends on reliable and valid ways of classifying patients into diagnostic categories. This critical research activity can enable investigators to better understand the etiology and pathophysiology of an illness. When diagnostic categories lack reliability and accuracy, the quality of treatment and clinical research can be significantly compromised. If ME/CFS is to be diagnosed reliably across healthcare professionals and scientists, it's imperative to provide specific thresholds and scoring rules for the symptomatic criteria. In conclusion, ME/CFS has gone from being considered a relatively rare illness in the early 1990s to one affecting about 1 million in the early 2000s. Now the CDC suggests as many as 4 million has this illness with the broadened criteria. These new estimates might include those with primary psychiatric illnesses, such as major depressive disorder. Using a broad or narrow definition of ME/CFS will have important influences on ME/CFS epidemiologic findings, as we've suggested, on rates of psychiatric comorbidity, on how patients are treated, on risk factors as to what might be implicated in the cause of this illness, and ultimately on the likelihood of finding biological markers. I hope that I've been able to suggest that case definitions can be a major impediment to replicating findings across different laboratories. For if investigators select samples of patients who are different on fundamental aspects of this illness because of ambiguities with the case definition, then it will be exceedingly difficult for investigators to consistently identify biomarkers. And this could lead to more psychogenic explanations of the illness. Over the past hour, we have needed to probe deeply to find out where some of the problems with our case definition might arise. And I thank you for staying with me as we have had to cover many relatively complex materials, including the field of epidemiology, issues of reliability, including criterion variance, sensitivity, specificity, and even Bayes' theorem. We often have people ask us if they can participate in one of our future studies. If you'd like more information, you can contact us at the email on the screen. I now am available to answer some of your questions, and I am going to turn this over to Kim McCleary.
Lenny, you have a couple more slides, is that right?
I do have a couple more that I was going to use for kind of maybe respond to some of the questions.
Yep, and the first question I'm going to ask, and this is a bit of a plant because it came in through the registration process from many of the people who registered for today's program, is about the American Psychiatric Association's proposal to create a new construct of mental disorders called Complex Somatic Symptoms Disorder, CSSD. And although CFS is not specifically named in that criteria, of course, the CFS Association, IACFS, and many other organizations have seen the potential for that new classification to impact people with CFS, and wondered if you could make some comments about that from your perspective.
Sure. Can you turn me back to my slides?
Yep.
And then I'll, this might take a couple seconds.
Sorry, guys.
Are you back? Am I back on?
You just need to hit your show my screen button. There you go.
Okay, great. This is one of the modern miracles of kind of technology. I've got my first button, my screen up, but my other ones aren't here. But I can talk briefly about that question as I try to somehow get my slides to move. The DSM is undergoing a revision right now, and as you said, this is a very controversial kind of diagnostic. And in a sense, one of the issues that many people are concerned about is that while it doesn't explicitly say that chronic fatigue syndrome might be kind of placed kind of into that particular category, it's certainly possible it could. Basically, you have to have a symptom that lasts for 6 months. There has to be certain characteristics of it that chronic fatigue syndrome very much meet. So many people are concerned that this widened category could be used to identify individuals who have kind of what we think of as ME/CFS. So I think that it's very important for individuals and organizations to get their comments in. And I might add that the CFS Association has put together a very strong statement. I'd encourage you to take a look at that. The IACFS ME, Fred Freeberg, and his board of directors have also put together a very strong statement, and I'd encourage those of you to take a look at that, because I think both positions clearly suggest that there could be much harm done by this new diagnostic category. Okay. Kim, I take it that I have some questions here.
You do. A couple of them, while you've still got the controls, one of them asked if the 6 factors in the DePaul study that you presented were presented in order of the percentage of variance accounted for. So I thought maybe you would want to go back to that slide if you can.
You know, I would go back to the slide, except my my screen is frozen. But that's a good question, and what that suggests is that in a sense, which factors basically account for the most variance. And you know what that indicates is that, and unfortunately I don't have those numbers in front of me, so I don't want to give out any misinformation. But certainly they all had at least an eigenvalue of 1, and they all basically would explain at least a certain amount of variance that would make sense to look at them beyond just as a particular item. But I think what's interesting, rather than kind of answering that particular technical statistical question, it's a very good one, is that, all right, so I'm no longer the presenter, so I'm basically I'm back here. But actually, what's nice about that particular model is that, you know, it's really an attempt, and I think that there's a number of research groups around the world that are really trying to use statistical efforts rather than a group of people coming together and saying this is what we think this illness is. I think ultimately using these types of things like factor analysis and other strategies to figure out what symptoms are really characteristic of this population. I think that's going to really push our field forward. And we can just see some really interesting work that's occurring, even at the genetic level at this point.
A couple people asked about the distinction between primary psychiatric disorders and depression in particular, and the kind of depression that many people with CFS experience, often at the hands of unknowledgeable or uncaring medical providers who either dismiss or downplay the severity of the illness, and how you can distinguish between those symptoms.
Yeah, that's a great question. You know, there's just lots of people who look at someone with classic depression and classic ME/CFS, and they don't get it. They don't see the difference between these two groups. And you know, if you don't understand the difference between these groups, then you ultimately put them together into one category, and this can have, you know, really some significant issues. You know, individuals with depression have actually different cortisol levels. It's usually higher. Those with ME/CFS have lower cortisol levels. So in a sense, you have different neuroendocrine functioning just on that one dimension, but many, many others. What I tried to suggest is that self-reproach. People with depression have a lot of negative types of things they say to themselves. This is self-reproach. They're very upset with themselves in different ways. People with chronic fatigue syndrome, ME, generally don't have that self-reproach. They're basically wanting to have their life back. They're wanting to get on with their life. They're basically seeing themselves as being limited. So in a sense, if you think about kind of the difference, one of my students, who's a graduate student at DePaul, just actually looked at that situation of those who had kind of different types of psychiatric issues. Some individuals with ME/CFS do have depression. I mean, the reality is any chronic illness that you have is probably going to cause you tremendous losses, and those losses could cause depression. What's interesting is when you talk to people, there's folks who have primarily a major affective disorder, like major depressive disorder, others who have really different ME/CFS. So really there's a lot of physiological differences, and there's on self-report measures, as I suggested, you can make 100% this kind of separation. The ME/CFS could make a generalization, usually feel in a sense demoralized, usually feel kind of upset that they can't do things. That's different from clinical depression. So that's the key difference. But if you're a primary care physician and you have someone coming into your office and you've got 10 minutes to try to figure out what to do, too often those individuals are going to make a claim of saying, oh, this person just must be just depressed because they're fatigued. And fatigue is one of the primary things that people come into healthcare settings complaining of. So there's many, many people coming in with fatigue problems, but not everyone has ME/CFS, which is different, as I've tried to suggest in this presentation, from many types of other chronic fatigues, as well as chronic fatigue that is caused by depression. And that certainly needs to be differentiated. It's a great question, very complex issue. I think it is one of the basic challenges to our field to ultimately try to collect homogeneous samples. And if we can get less heterogeneous samples and more homogeneous samples with the key characteristics of this illness, we have a chance of not only producing better, I think, prevalence numbers, but also of identifying those people who we can then look at these biological markers and see if they're common across labs. To the extent that different laboratories have different people with different primary characteristics, and one group of people might have more affective depression in their group and maybe not even ME/CFS, well, that sample is never going to have the same biological markers if you have another group that has really primarily ME/CFS sample.
Let's kind of turn that one on its side, if you don't mind, and talk about several of the questions have asked about biomarkers and how biomarkers will affect the definition of CFS, and thinking about things like XMRV. You mentioned the light study of post-exercise markers in CFS. How can you speak to the effect of how different biological findings may regroup or redistribute the way that the case definition is shaped?
Yeah, I think that's, as I said really at the beginning of my presentation, I think these are exciting times. I think that there are people doing work with proteomics, with genetics, people who are kind of, giving challenges. It really seems like whether it's in the nasal area or whether it's in peripheral blood, that we're seeing kind of really challenges that seem to kind of elicit these types of changes in some of the genetic markers or some of the receptors. So that's exciting, and I think ultimately, and that's why the last slides I really started talking about more biological measures. Our group in Chicago is now trying to write a paper where we're going to try to take every symptom and try to say, this is what we have, level 1, level 2. Basically this is self-report, and this is one level, and that's okay, but here's the next level. If you basically meet criterion on this, for example, exercise challenge, that will basically be the gold standard. And I think ultimately that's what our field is going to go to. It's happened in other fields like with MS, where ultimately you come up with kind of measures that basically say, yes, we think this is kind of the illness, and these are the types of characteristics that fulfill it. That's where our field will go, I think, in the next 5 to 10 years. There's no question that the genetic work a sign for tremendous hope among the people who are out there in the audience. We are close to making breakthroughs, and the hope is that scientists will select the right people, carefully defined, so that they can find these biological markers. And once these markers are better understood, we will ultimately begin to understand some of the basic central processes that are basically causing the many symptoms of these illnesses.
Lenny, there's a lot of interest in the symptom of post-exertional malaise, fatigue, exhaustion, and I have to admit I was responding to questions when you were focusing on that part of the presentation, but a question came in about whether the new measures that your group is proposing and the way that you're asking about that symptom, whether it also incorporates not just physical effort but also mental and cognitive effort, and the relapse that many people experience after trying to do their taxes or help their kid with third grade math even, that has almost the same effect as physical effort does.
Yeah, that's a great question. There's no question that it's not just physical activity that can cause these types of symptoms, and mental activity can also do this. There has been some work that has been done in that area, and certainly I think that the reason the exercise challenges are so interesting, Stacy Stevens and the Lights and many others who are just doing such incredible work in this area, are that it's really much easier to quantify. Basically, having a person kind of do submaximal or maximal exercise, depending on Dane's work is also very important. So the key question is, how do you operationalize it so that you can actually have a person go through a procedure and then see these types of changes, biological changes? And ultimately, probably a little bit more work now has been done with the physical challenges. I hope that the other types of challenges will also be more explored. There's some preliminary work in that area. There's no question that both of these types of challenges are going to have physiological changes that could be used by us to help, again, identify patients who have this very interesting phenomena of post-exertional malaise. It's just such an interesting phenomena. Remember, with depression, getting back to the depression versus ME/CFS category, you take a person with major depressive disorder and you tell them to start working out, do some aerobic exercise, get more active, they feel better. They will come back and report, gee, this is making me feel better. Isn't it interesting that the ME/CFS person who's told to start getting a little bit more active and to start pushing themselves a little bit, they will experience post-exertional malaise. So you have, again, two fundamental different kind of events occurring for two different type patients. So why would you want to put them both together? You put them together and you're never going to find those types of biological markers that are specific for ME/CFS. So again, an excellent question, and I think that very similar types of genetic changes probably could occur. Again, this is something that we need more research on.
Okay. Several questions about the Canadian case definition and how it might be more widely distributed and circulated. When it was published in the Journal of Chronic Fatigue Syndrome, which is no longer active and wasn't ever Medline or PubMed searchable. I know you've been working with the authors of that definition, and maybe you can share some of your thoughts about how to get that into the hands of more clinicians and researchers.
Sure. The Canadian criteria were developed in 2003, and our group in Chicago looked at them very closely, and we tried to take what they stated in their manuals as well as in the Journal of Chronic Fatigue Syndrome and just operationalize it and try to get real specific about whether you count it or don't count it with a particular person. And we had some difficulties. I mean, the reality is that operationalizing the Fukuda criteria and the Carruthers, the Canadian criteria, is not always the easiest for researchers. Now, with the Canadian criteria, that didn't stop them from using it. The Canadian clinical case definition, because they say it's a clinical case definition, some people said, well, it maybe shouldn't be used for research purposes. We have been struggling for the last few years trying to figure out, why it's not being used more. And our first effort in this area was with the Pediatric criteria, which we really used the template of the Canadian folks to work on that. And we had some success with that criteria. And now we're actually trying to kind of concretize the work of the excellent work that the Canadian authors put together. Now, it might sound simple, but it's very difficult. We have a questionnaire that we have developed. We've sent it out to probably about 25 people around the world. We have a team that sits down and sort of says, well, how should we phrase this? How do we capture it? And we had one group from Great Britain that were saying, well, they use this word a little differently there, so how do we use that particular word? Very hard to operationalize things so that everybody will use the same stems, the same questions, so that we can have everybody on board. And that's what we're hoping. We're hoping to begin collecting data now with the questionnaire that we've developed. We have a name we've written that we'll eventually be sending off. We're hoping to present some of the initial data at the next major CFS ME conference. By that time, we'll have some of our data collected. But we think that we certainly would encourage people who want to collect data to think about maybe using the Fukuda and the Canadian criteria and seeing what they find and seeing if they are finding similar groups or somewhat slightly similar groups. And I think that using both case definitions is something that I would encourage, and I hope that it comes to a point where you actually see the Canadian criteria used. At this point, there's really only been a handful of studies that have actually used it, and we'd like to see that changed.
And I would note that, and I'm going to actually advance my slide to make this point, the association just launched the Solve CFS Biobank, and we are enrolling patients for the first study using the biobank, and the eligibility requirements use both the Fukuda and Canadian definition, because as you say, it's not as easy to operationalize as one might hope, but we're hoping through the eligibility criteria that we've established to really encircle a more homogeneous group of patients, as you suggested earlier in your presentation. And so we're excited about what that opportunity to really look at a very well characterized group of patients will bring to advance the research. If you're not familiar with the biobank, I'll just put a plug in to visit our website at www.cfids.org. And I did have a slide with some URLs on it, and I'm not sure what happened to it. But we've also been working with Lenny on the questionnaires that will collect the information directly from patients about their symptoms and medical history, medication history, etc., and hope that the biobank will be a resource for the expansion of his research on how those tools and operationalization through questionnaires might be enhanced as well. So we've enjoyed that partnership on this new biobank. According to my watch, we're a little bit over time. I'm just astounded. We still have 185 people on the line. So bravo to all of you who have lasted for 90 minutes. I know even though you may be reclined or in a comfortable chair, and you don't have to be in a hotel ballroom in an uncomfortable straight chair at a desk somewhere sitting to listen to this, it is still exertion and requires your attention to focus in on the computer and the dialogue as well. So thanks for hanging with us. Lenny, any parting comments before I just make some closing remarks?
Well, I just want to thank you and the CFS Association. I certainly have enjoyed this webinar, and I'll look forward to kind of hearing more about other webinars you do in the future.
Great. Well, thanks for helping us pioneer this series. And this was Dr. Jason's first webinar, and it is a bit of an odd experience. I mean, all of us are sitting here probably by ourselves, but when you're speaking and looking at a computer screen, it makes you feel just a little bit like an out-of-body experience. But you did a great job, and one person even sent a comment that they teach public presenting, and that you were doing a fantastic job from that standpoint. So I'll pass that on to you in email.
Thank you.
For those of you still hanging with us, I just want to make sure that everybody's aware that our webinar series, we have expanded. We had initially planned to do one program a month, and we were able to get some support from a family that wishes to remain anonymous to expand that and to really utilize this technology and this opportunity to bring a really dynamic group of speakers to you. We have 3 upcoming webinars on sort of more medical research topics for those who sent questions about some of the things like biomarkers and treatment issues on the clinical side. Coming up on May 4th with Suzanne Vernon, who will talk about 3 of the 6 projects we're funding. Dr. Charles Lapp here in Charlotte at the Hunter Hopkins Clinic will describe his approach to treatment of CFS. And then Suzanne will be back with us on June 8th with Dr. Liz Horn from Genetic Alliance to talk about the Solve CFS Biobank. We have a list of the other topics that will be coming on our website. We have another program planned for next week, but we're having a little bit of scheduling difficulty, so that one may be rescheduled for the future. But we're just real excited about this series already. We've had more than 1,500 people participate, and that's just really something that we couldn't do without this kind of technology and people being willing to sort of take us up on this offer. Going to move on. We will be sending a follow-up email to everybody who participated today with some of the URLs that were mentioned. I know a couple people missed the email address. If you're interested in participating in Dr. Jason's group studies for the biobank, for the upcoming webinars, for where to find the recording of this program and the slides after the fact, and some other resources that came up in the content during the content of the program. So we'll be getting that out to you later today or tomorrow morning so that you have all those things in your email in case you didn't catch them as we were going through. So on behalf of everyone here at the association, we really appreciate your participation, your support, and your engagement in this. And thanks so much for participating. Have a good afternoon, rest of your day, evening, or whatever you have left of the day before U.S. Tax Day. Thanks again, Lenny, and take care.
Thank you.